Welcome, everyone. We're glad you could join us for today's presentation, Enhancing Service Line Performance Through Gainsharing and Comanagement. I'm Kevin Forster, a principal at ECG, and I'm pleased to be your moderator for today's session. Before we begin, just a few updates and background information. We did think about renaming this presentation in light of everything that's going on in the market and environment today, but we hope that maybe we should have called it a reprieve from COVID-19. We do appreciate everyone joining, and particularly given these remarkable times we're all going through. In terms of our content today and the speakers we've assembled, it's really focused on how physicians and hospitals can align better together to enhance service line performance. And we really think that this is the result of purposeful planning that need to combine both the vision, strategic direction, and strength of a health system. The transition to value calls for health systems to rethink and redesign delivery systems. We know this. We also know that it can be very challenging. Co-management and gain sharing are two arrangements that we believe are both complementary and facilitate the alignment necessary to enhance many aspects of service lines. During today's presentation, we'll discuss best practices in gain sharing and co-management arrangements, program development approaches, funds flow and compensation, the valuation approaches we take in these arrangements, as well as relevant legal and regulatory agreements. Before we introduce today's speakers, let me go over a few ground rules. Today's program will be 75 minutes in length. Everyone should have received a copy of the session handouts, but if you are a late registrant, you can download the handout in the handout pane on your screen. Attendees are participating in listen-only mode, but if you have questions, you can type them into the question pane on your screen at any time, and we will address them at the end of the formal program. If we're unable to answer any of the questions, we will follow up with you after the session. We will be, throughout the session, be launching an audience polling question, and we hope that you'll participate in this. Finally, at the end of the session, you'll be directed to an electronic survey where you can provide feedback. We'd really appreciate it if you can do this, and for those that do complete the survey, ECG will make a $5 donation to Doctors Without Borders. Now let's meet our speakers. Tom Dutton is a partner at Jones Day. Tom works with hospitals, health systems, payers, large medical groups, and really is on the cutting edge of many of the transactions, strategies, arrangements that these organizations are entering into. And he has years and years of experience with co-management, and so he will be speaking both from a strategy and a regulatory perspective on this topic. Welcome, Tom.
Thank you, Kevin. Happy to be here today.
John Fink is another speaker, a principal at ECG, and has been consulting in healthcare for approximately 25 years. Over the last several years, most of John's work has been related to establishing beneficial financial relationships between provider organizations, so physicians, hospitals, and often payers. And he brings a wealth of both knowledge and experience related to co-management and gain sharing arrangements. Welcome, John.
Thanks, Kevin. Looking forward to today's discussion.
And finally, Jason Lee is an associate principal at ECG, and his focus over the last several years has been on the shift from volume to value. And within that space, he is an expert in terms of developing value-based provider compensation arrangements, which comes into play, obviously, when we're talking about co-management and gain sharing arrangements. Welcome, Jason.
Thank you, Kevin. Good morning, everybody.
So with those introductions, I'll turn the program over to John to kick off the formal presentation.
All right. Thanks, Kevin. And thank you to everyone on the call for joining us today. During this webinar, we ask that you keep in mind the enhancing service line performance part of the title of the presentation. And these two complementary financial arrangements are just tools in helping to enhance service line performance through greater collaboration and alignment among physicians and the health system. Tom, Jason, and I have developed Gainsharing and Comanagement arrangements in a variety of environments, single hospital to multiple hospitals, just inpatient, just outpatient, both inpatient and outpatient, one specialty, a bunch of specialties together, different alignment with physicians, already in place, including, some where the doctors are employed by the hospital. And we've also worked with organizations that have had arrangements in place and helped them make them work better. But we're going to go through, as you see in the agenda, we'll talk through the various models and then how they can all work together. But so first on slide 4, focusing on service lines. At the end of this past year, like every year, we talked with a number of health system leaders to discuss the core challenges that are keeping them up at night. And of course, those have changed recently, but what really topped their list was an overall pressure to function more progressively and better integrate across traditional silos. And leaders expressed concerns like, one, a quote of enhancing our delivery system in a way that stamps out variation, improves quality, reduces costs, and enhances the patient experience. Another was moving from the traditional market capture and preservation view of service lines to a view that is focused on quality and the reduction of harmful events. And so the situation is that providers really need to demonstrate value at this time by, one, providing high quality care through greater standardization, use of clinical pathways across the continuum, and greater use of evidence-based guidelines. Secondly, enhancing financial performance by generating more revenue and optimizing costs. Third, growing through targeted clinical portfolio management and optimizing where services should be provided, inpatient, outpatient, physician office. And fourth, improving collaboration among providers to improve access to care and the transitions of care from provider to provider. If we move to slide 5, service lines need to support the quadruple aim and drive strategic market positioning. You can't achieve, value without good outcomes, without low costs, and without a positive patient experience. And you can't achieve any of those without a positive clinician experience. So strengthening alignment with physicians will enhance the delivery of exceptional personalized care and enhancing the organization's local and regional market positioning. And that's where Gainsharing and Co-Management come in on slide 6. Gainsharing and Co-Management, they're complementary. We keep saying that. They're complementary alignment models, and they help strengthen the alignment with physicians, allowing for targeted improvements in priority service lines. So Gainsharing allows the organization to quickly achieve cost savings and by reducing costs associated with physician preference items and other identifiable and measurable savings while protecting against stinting, cherry picking, and steering. While co-management provides a longer-term approach to empower physicians to lead the service line. And we're able to establish that long-term structure so you get the quick wins from Gainsharing, and then also show to the physicians that we're willing to share in that savings if they're able to help us achieve what we're trying to do, and also have the long-term structure for continuous improvement. Now,
so John,
go ahead, Tom.
So John, this is Tom, and so let me just throw in a few observations from our work in helping many health systems and hospitals around the country set up these strategies. And again, as John has already described, I mean, the reason why we are having this program today, and is these are strategies that we actually have seen work over and over again around the country, and the classic indicator of why that is true is, for example, in co-management arrangements, is usually no one does just one. The common service lines usually are cardiovascular, orthopedics, oncology, but I mean, we've done them in GI, we've done them in women's services. I mean, it can be applied to any service line. But wherever a hospital or health system has started, it's usually been so successful that they want to do another, and usually a second or a third. And the reason why, again, and we think that this is important to again revisit these strategies in the case of co-management and focus on gain sharing, given some of the recent regulatory changes, is because they really have worked. They actually have resulted in physicians assisting the hospitals to improve their quality outcomes, to improve their efficiencies and throughputs, to improve patient satisfaction scores, et cetera. And what we always hear when we're going around the country is that physicians usually will have a couple different things to say as to why things have not gone as well as they could. Is because they often will say is, number one, the hospital won't listen to me. Yeah, sure, I have suggestions, but they won't listen to me. I don't really have a seat at the table. And then even if you cross several, they'll always say things like, well, I mean, I'm busy. I have a busy practice. I have a family I need to take care of and spend time with. Why should I do this? Where's my reward for helping to improve the hospital operations? And that's what these strategies are really designed to do. Number one is to empower the physicians, to really give them that kind of mental ownership of the success of the hospital service line. And then, frankly, to, with proper incentives, to reward actual improvements in performance. And because these have been so successful, it is again time to revisit them, because in these coming days, value-based care is becoming more and more important, and sooner or later, hospitals and physicians are going to have to start assuming more risk. Back to you, John.
Yeah, I think that's a real good segue to our first polling question.
Thanks, John. You should be seeing on your screen now several questions, and we'd appreciate if you would take the time to quickly answer these. Again, the responses are, and again, we're just looking to get a feel for how prevalent this is amongst the audience participants. So first response would be, we use co-management but not gain sharing. We use co-management with gain sharing. We use gain sharing as part of a bundle program, such as CJR, BPCI Advanced, etc. We use gain sharing on its own, but we don't use either gain sharing or co-management. John and Tom, as we wait for some of the rest of the audience to fill this out, maybe you can also comment on, I would imagine that we're seeing more of the gain sharing and co-management, not only with value-based programs evolving, but also more and more organizations evolving to more of a service line orientation. Is that a true statement that you're seeing across the country? Tom?
I would say indeed that focusing on service lines is becoming more and more critical. I mean, let's be honest, there's probably only, fill in the blank, 1, 2, 3, or 4 service lines that those service lines may be generating 80% of the bottom line for a hospital or a health system. So it is absolutely critical that those critical service lines perform well. And again, what we have seen in practice is this is actually a strategy that does what it's supposed to do. It does result in higher quality performance. It results in greater efficiencies and the obtaining of lower costs. So it is something that we are indeed seeing a lot of.
Yeah, and what I would say is in the polling responses here that you got, with a quarter using co-management but not gain sharing, half of the people not using either, 13% using gain sharing on its own, and 13% using co-management but not gain sharing. I'm sorry, with gain sharing. What we're finding is that there's neither of these are new, and many of our clients have been using co-management for a number of years, but have avoided gain sharing for good reasons until recently. And I'll let Tom go into those details. But I think what people are, one thing with combining them, they're now recognizing the benefits of using both programs together. They're also seeing co-management spread not just at a single hospital, but regional systems that are having a greater service line perspective, Kevin, but also having it across all of their facilities, not just individual hospitals. So we're seeing arrangements that spread across multiple hospitals more and more. And that's what we've been active in helping people with more recently.
Well, and we'll get into this in greater detail in a little while. But I mean, the reason why gain sharing is I think becoming more and more of interest to hospital administrators is that there is greater flexibility now. That given the recent regulatory changes that Congress adopted with respect to the civil monetary penalties law, there actually is now some real opportunities. And I think a lot of people view the cost savings opportunities as potentially low-hanging fruit that can literally produce millions of additional dollars in savings to hospitals and health systems by pursuing those strategies. So we'll get into that in a little bit greater detail in a little while. So let's get back into the presentation. If we could go to slide 8. And in looking at the registrants, it seems like we have a pretty good mix. Probably half the folks are hospital administrators and half the folks are lawyers. So I won't spend a ton of time on the regulatory piece, but just kind of lay the groundwork for what we're dealing with. The gain sharing program and the co-management programs will implicate many the common healthcare laws, the anti-kickback statute, the Stark law, civil monetary penalties law, if you're a tax-exempt hospital, the tax exemption restrictions, antitrust issues, and of course, most states have state law corollaries to those. Moving on to slide 7. Again, just at a very high level, the anti-kickback statute, to remind you, basically says it's a federal law that prohibits the provision or acceptance of remuneration in exchange for referrals of patients who are in federal healthcare programs. Wrongful intent is required. Fortunately, there are regulatory safe harbors that have been adopted over the course of time. If you fall within a safe harbor, you are indeed not in violation of the law. The applicable ones that will come into play here are found at 42 CFR section 1001.952D1. And to basically, if you look at that safe harbor, probably most co-management arrangements and most gain sharing arrangements will meet the existing safe harbor for personal services and management contracts, subject to today, one of the requirements of that safe harbor is that the aggregate compensation to be paid must be set in advance. Given the nature of the co-management construct that, usually half of the monies are put in incentives and hence are not guaranteed, you actually don't know what the aggregate compensation paid will be. Likewise, given that gain sharing is a 50-50 sharing of cost savings, once again, you won't know what the aggregate is that will be set in advance. In the good news category, however, in the proposed revisions to the safe harbors published last fall, they are proposing to change that requirement so that rather than having the aggregate compensation be set in advance, that only the methodology for determining the compensation be set in advance. It is expected that that change will be adopted when the final regulations are published. And if that is the case, then frankly, most co-management and gain sharing arrangements will qualify for the safe harbor. Today, as I say, most do not just because of that aggregate compensation, but that is not a fatal flaw because failure to meet a safe harbor does not make an arrangement illegal. Let's move on to the next slide. And again, if you're familiar with the proposed regulations, they actually have a new proposal for an outcomes-based payment safe harbor. That actually, to be honest with you, does not really pick up either current co-management arrangements or gain sharing programs. Although there is a chance that it might be changed to pick up the gain sharing arrangements, because at the moment they are excluding from the scope of that internal cost savings, cost sharing programs like gain sharing. I don't personally think there's a good policy reason for that, and it'll be interesting to see what comments the government received on that. So it's possible they might apply this to internal cost savings programs, but just assume for the moment they don't. But the reason why I put this slide here is, and particularly if you look at the second bullet and all of the little sub pieces of that, is when you're going to design your co-management arrangement agreement or your gain sharing agreement, there's a lot of good indicia in that regulation, the safe harbor, that we would want to put into these programs. So again, regularly monitoring and assessing performance as to whether the arrangement has measurably improved the quality of care, whether it has resulted in any deficiencies in the quality of care, whether the agent has met outcomes measurements, quality gates, so to speak. Are you measuring the clinical outcomes with stated goals? Are they evidence-based metrics? You know, if you can just kind of work through all of this, those are all the types of things that we want to build into our co-management and gain sharing arrangements. Moving on to the next slide, the START Clause, again, really quickly, just to remind everybody, you're not allowed to basically, it prohibits an entity from billing Medicare for designated health services, which includes, in particular relevant here, hospital inpatient, outpatient services that are referred by a physician if there's a financial relationship between the entity billing for the service and the physician that made the referral. This includes financial relations, includes both direct and indirect ownership and compensation arrangements, and intent is irrelevant. You either meet an exception or you don't. Fortunately, here in gain sharing and co-management, there is a personal services arrangement exception that usually comes into play. And likewise, depending on your structure of the co-management company, the indirect compensation arrangement may also come into play. We'll obviously get into applying these laws later in the presentation. Moving on to the next slide. Again, civil monetary penalties law. The great thing was in 2015, Congress changed the law that basically had put a huge damper on gain sharing programs. Prior to the change in the law, the government, in the view of most legal authorities, including me, would say that they were incorrectly applying the existing civil monetary penalties law to say that you couldn't have a program where a hospital was making a payment to a physician to help incentivize the physician to reduce medically unnecessary services. That actually was then clarified, and the regulatory interpretation was overcome when Congress changed the law to basically say, yes, you can have cost savings and incentive payments to physicians for helping to reduce medically unnecessary care. And that's why I think that if you haven't already been actively considering a gain sharing program, you should, because it is a cost incentive program on steroids. And we'll explain that in greater detail as we go through the program. Again, moving on, the classic co-management structure usually looks something like this. Usually there is a separate co-management company that is set up, so you have issues regarding formation of that co-management company. It is usually owned by the physicians who are actively involved in the service line and are actually in a position to help the hospital affect the positive changes that we want to see with respect to quality, efficiency, et cetera. Usually the equity investment is somewhere broken down somewhere between 50-50 all the way up to 80-20 is kind of where I usually maximize the physician investment. And the equity investment usually relates to the startup costs for the company, which is often the costs associated with the financial consultant who helps to do the baseline assessment and provide the fair market, obtaining the fair market value opinion, et cetera. Legal services associated with the startup as well. One of the nice things about this particular model is it does result in physicians having skin in the game, which from a regulatory perspective is always a good thing. On the other hand, it's usually not so large as to be an impediment to physicians wanting to be involved. I've seen investments from physicians as low as $5,000. Probably the maximum I've usually seen is somewhere between $15,000 and $20,000, with probably the most common somewhere in the $7,500 or $10,000 range. While the equity may be 50-50 or all the way up to 80-20 in favor of the docs, it is a true co-management structure. So the governance, regardless of the equity, is always a 50-50 structure. And often it's usually set up through a class voting structure. So frankly, you can have anywhere from 5 to 9 doctors in the physician class of directors, and as few as say 3 hospital administrators in the hospital class. But each of those classes exercises half of the governing authority. With respect to the contracts, obviously one of the most important contracts is the management service contract between the hospital health system and the co-management company. That's the contract that will detail a comprehensive set of duties that is being put on the co-management companies, and the thing that frankly will excite the interest of the doctors. This is how you then are empowering them, albeit in a co-management structure. They don't have unilateral authority, but they'll now have a seat at the table with the key people at the hospital to talk about things like, what are the operating and capital budget? What are the services we're going to offer? What equipment and supplies do we want to have? What locations where we want to have services? Do we need to recruit additional subspecialists? What's the staffing plan for these services? All of those things that the doctors have never really had input into before are all part of the comprehensive set of duties in the management contract between the hospital health system and the co-management company. That is then what allows an independent third-party company to come in and appraise the value of those services, and that it allows for usually significant compensation to be paid by the co-management company to by the hospital to the co-management company, and then ultimately back to the physicians who are performing services. Moving on to the next slide and turning it back over to John.
Yeah, and slide 13 is, as Tom was saying, that's definitely the preferred structure. It's what we see most commonly. It's what we encourage organizations to do. We wanted to throw in slide 14 to show you what we think of as the lazy administrator structure. This is where there's a feeling of too much pain of actually forming a management company that everyone would own together. And so as an alternative, identical agreements are put in place with each group between the hospital and the groups, or in this case, there's a couple physicians where it is included as well. This removes the need for a separate LLC to be created to serve as the management company. But the main problem with this is that the collaboration among physicians within different groups is exactly what we're seeking through these arrangements. And so creating a company together is a great start to make that collaboration start to happen so that it can then run the service line with the health system. We find that there are other times, though, where there might just be one group that the hospital is contracting with, in which case that group can serve as the management company as well. So if every single doctor within the service line is in a group together, that makes sense to do. What we've found is that there are, when there are lots of independent doctors and lots of groups involved in the service line, rather than just one group, it's much more challenging to put the management company together as well as a gain sharing arrangement. But the benefits are much greater because when there are so many different groups and so many independent doctors in a service line, the standardization is much less. Everyone's doing things their own way. And so the benefits of putting these arrangements together in those more fragmented situations are even better. Slide 15, that shows the management company, how it typically receives compensation through base or fixed fees on the left side of the screen, and the incentive or variable payments on the right side of the screen. Slide 16 goes into a little more detail. A key step in this on slide 16 is the identification of potential incentive metrics. First we need to figure out, okay, well, so what are the main categories? These are pretty static on the left side of the screen: quality, efficiency, satisfaction, development. So this does not include a gain sharing component to it. Those are usually the categories. And then this looks like it's probably more like an ortho or example that we have here. But what are the exact metrics that we would want to be using for them, and then how much money would we put towards each metric? So in this example, we have $1 million of potential incentive compensation if the management company is able to achieve these performance incentives over the course of the performance period, which typically a year, and it may have pieces within that year to have the measurement performed. I guess the only other thing to mention is that we'll often see that the payments are made with various tiers. So certain amounts of the $75,000 is the potential maximum incentive for any one metric. You may be paying $25,000 if they achieve a certain measurement, $50,000 if you get to another goal, $75,000 if they do really great in the performance. Okay.
So John, if I may, a couple things I would throw in here, which is when you are going through the development process, you're going to need to hire a consultant, and frankly, obviously, ECG does this work, as you can tell. But you're going to need a consultant to come in and work with the hospital to conduct the baseline assessment and interview the administrators, interview the key doctors in the service line. And it's a process by which you discern what are we doing well, what are we not doing well, what should we really be focusing on in trying to improve. The other thing that the consultant does together with the legal counsel is works in identifying and then working with a hospital physician steering committee, usually somewhere around 5, 6, 7 doctors in the service line, to again go through this process and be the sounding board for again what are we doing well, what are we not doing well, help to determine what is the scope of the program that will be subject to the co-management arrangement, usually defined by DRG, CPT codes, etc. And then as well to help determine which physicians are those who are in a position to help the hospital achieve the change that is designed to be accomplished. And if you actually go through this process and do it well, then usually it is successful. And that's why I said early on that often hospitals have done this, usually don't just do one, they usually do 2 or 3. And just to give you some examples, we've seen dramatic improvements in AMI, CHF, SCIP, core measure scores, dramatic improvements in door-to-balloon time, dramatic improvements in on-time starts, turnaround times, patient satisfaction, block utilization. Obviously, it depends on the service line on which some of these would apply to. But it really does result in significant improvements. And frankly, not all of them are going to be taking a program and moving it into the top decile. I always remind hospitals when they're focusing on a metric that's top decile, it's like Well, you understand simple math, right? So only 10% of the hospitals in the country can be in the top decile. If you can get there, reasonably through, working hard, great, go for it. But by the same token, if you have a patient satisfaction score that's at the 25th percentile, if you can move that to the 40th percentile, the 50th percentile, the 65th percentile, that's a great thing. And that's kind of my other little phrase is, look yourself in the mirror. Again, if you can get to top decile performance, go for it. But any meaningful improvement is still a good result. So with that, why don't we move on to some of the issues associated with the offering of the interest. And again, what we would recommend, because you don't want to have this be considered that you're basically paying remuneration to people who are referring business in the service line, is that you only offer interest in the co-management arrangement to those physicians who are actively participating in the program at the hospital. Don't offer it to referring physicians. The classic example would be primary care physicians. As I mentioned before, we like the separate co-management company model because it results in the physicians having skin in the game, picking up on some of the things, and I cite there at the top, your relevant legal authorities are the investment interests in personal services and management contract safe harbor, as well as OIG Advisory Opinion 1222. One of the things that you'll see in the investment safe harbor is, you shouldn't be loaning physicians money to make the investment. Usually the amount to make the investment is low. It's a rare bird that there will be a doctor who can't afford the $7,500. Banks will be happy to loan them the money when they look at the pro formas from the likely results of operations. So you don't want to loan the doctors money. Same terms. The other phrase here is, of course, good for the goose, good for the gander. So whatever the terms of the offer are for the physicians should be the same for the hospital. The physicians are paying $7,500 for an interest. The hospital should pay $7,500 for an interest. Because we don't want to have the size of the investment based on the value or volume of the referrals. Almost always these are set up so those physicians who are investing each only own one unit, and then all distributions of profits are distributed on the unit basis. So they're all basically just getting that per capita share of the profits. And there obviously should be no requirement to refer. Moving on to the next slide, this actually lays out some of the key relevance terms for the management contract itself. Classic stuff you should expect. Services should be specified, reasonable and necessary for legitimate business purposes. Probably the biggest thing you always have to work out, be on the lookout for here is to make sure you're not paying for the same thing twice. Where you classically would want to double check in your due diligence are medical director agreements, bundled payment programs, employment agreements. Where we have had those covenants that might be considered as overlapping, we usually amend those contracts prior to entering into the co-management agreement to eliminate that overlap. Again, you want to have the base compensation and the methodology and the cap on the incentive compensation set in advance. Should be consistent with fair market value without taking account the volume of value referrals and be commercially reasonable. You cannot set it on a percentage basis because that's viewed as directly tying to the volume of value referrals. Often you can, if you want to know, there's kind of a rule of thumb you can use, even though each year the amount will be prospectively set in advance. It's kind of an inverse relationship to the size of the program. If you have a service line that has $5 million of net patient revenues, you're probably looking at the equivalent of a fixed equivalent of a 5 or 6% of net patient revenues. If you're at $40 million, you're probably looking at 3%. As you get closer to $100 million, then you're more like getting closer to 2% or 1.5%. But again, those amounts will be set prospectively in advance, and you always want to have those supported by nationally recognized a firm giving you a fair market value opinion. The incentives themselves should only be paid for improved performance. You want to make sure you define those metrics so they don't trigger anti-kickback or CMP issues. So in other words, don't tie them to growing revenues or net income or rewarding the reduction of medically necessary services. Then there's just other classic stuff in writing, signed by the parties, duration of a year, etc. Moving on to gain sharing. So gain sharing, again, we often used to put a metric in the co-management arrangements to try and incentivize the cost reduction activities, but because the overall comp for the fair market value opinion on the management services agreement, there's just kind of methodology for that. It really didn't support putting a lot of money behind the payment to physicians for the achievement of significant cost savings. That's why we are recommending now that you actually separate the two programs. And usually the gain sharing presents low-hanging fruit if you have not already worked with your doctors on supply standardizations and other cost initiatives. And the way these programs work is that you can pay up to 1/2 of the cost savings to the doctors. And just monetarily, those numbers will work out to be substantially greater than if you had an incentive within the co-management arrangement. So while the gain sharing program is likely to be of a limited duration, it is likely to provide a pretty big bang for the buck and incentivize the physicians to help the hospital achieve significant cost savings. When we go about this, and we'll talk about this in greater detail, obviously you need to have the program supported by quality metrics. Is that medically, if you're going to do supply standardization, there can't be a reduction in the quality of the services that are provided to the patients. You need to be able to track exactly, the savings and know that what's being done is producing those savings. And we'll go into greater detail on those as we get further into the discussion of this program. Turn it back over to you, John.
Yeah, just on slide 20, it just shows that how gain sharing can be mostly, it's favorable conditions or when there are clear opportunities for cost reduction and quality improvement. And you can also effectively measure those improvements and cost and areas where you're saving money for the hospital. So costly physician preference items, high supply and drug costs. You can see here, this is a cardiology slide. It's a common neurosciences, orthopedics, of course, and some of the other major specialties, but especially those with high supply costs. Now, we should point out that we're focusing primarily on internal cost savings for a hospital, in contrast to savings from cost reductions in areas like post-acute care, from an episode of care, or from a bundled perspective. Organizations with substantial ACOs may seek gain sharing beyond just the costs that are in the hospital. And bundled programs like BPCI Advance or CJR, those provide opportunities for gain sharing for savings to the payer from managing the episode costs, as well as savings to the hospital for savings on internal costs. But most of what we're talking through at this point are focused on the savings for the hospital. Move to slide 21.
So this slide describes a lot of the common features of gain sharing programs. Again, the basic core of a gain sharing arrangement is a contract between the participating physicians and the hospital. And you need to define with specificity what are the services that are the subject of the arrangement. And that can be defined by, DRG, other methodologies. And you're going to need, again, to hire a consultant to come in and work with the hospital to massage the data to make sure you really know what your existing baseline costs are for these different services. Because that's then the basis upon which you're going to make payments to the physicians for helping to improve off of that baseline. Specificity is clearly necessary You're going to have again, the hospital and the physicians working together, often with the business consultant, to identify what are the ways we can reduce medically unnecessary costs through, again, supply standardization or other strategies that are designed, as John focused on the previous slide, to eliminate unnecessary costs. Physician participation, we'll talk about this in a little further detail in a little while, but the point is, again, just like co-management, you really need the doctors who are actively involved in the service line to help you identify how you can improve these costs, to decrease these costs. You'll establish through the definition of the services the potential source of the pool. You'll monitor the performance on usually a quarterly basis. You can have payouts on a quarterly basis with a reconciliation on an annual basis. These are the types of components that you're going to want to have as you're developing the gain sharing program. Moving on to,
if I could just add one element there. When we're reviewing these arrangements for fair market value and commercial reasonableness, as Tom was alluding to, one of the key pieces here is establishing your definition and ensuring that that definition is repeatable, so that when you're calculating the savings in the future, the methodology is the same, the steps to derive the rates and the expected and projected savings are consistent with that original definition. So the key piece of our review is ensuring that that's in place, that folks have been following those definitions and those methodologies going forward.
So focusing on slide 22, as I mentioned at the very beginning of the program, gain sharing as long ago as the late 90s was recognized by the OIG as being potentially a very positive development for hospitals, that properly structured cost-sharing arrangements can serve legitimate business and medical purposes. Unfortunately, as I said, shortly after that, in the early 2000s, CMS basically said, sorry, but we're taking a very strict interpretation of the CMP law, which basically resulted in the elimination of most people's interest in these programs. But nevertheless, as you move on to slide 23, there have been, over the course of the last close to 20 years, 16 advisory opinions from the OIG on permitted gain sharing programs. And in addition to those OIG opinions, the other relevant legal authorities, again, would be the Personal Services and Management Contract Safe Harbor, and there was also a special advisory bulletin on gain sharing. We're going to first go through what the requirements are if you're conservative, if your organization's conservative, and you want to structure one of these to comply with the OIG advisory opinions. We're going to first go through what those are, and then we're going to kind of like revisit these and say, some of these, are they really necessary for the program to be legal? But starting first with the OIG advisory opinions, this is the way pretty much all of those 16 OIG advisory opinions were structured. There was a program administrator that was hired to identify in advance and the potential cost savings, and then is to develop cost savings caps for those potential cost savings. The classic examples were product standardization or reducing the use of certain supplies to when only medically necessary. There was a built-in floor. Cost savings were calculated on an actual out-of-pocket acquisition cost basis. It was based on all procedures. And then there was a volume cap so that if a participating physician's volumes went up during the course of the year, those additional volumes would be excluded. In every one of these cases, there were quality gates that were established to ensure that there was no decrease in quality. Moving on to the next slide. Again, the way these programs were set up is after the payment of the program expenses, usually associated with the administrator, the hospital would pay 1/2 of the cost savings to the physicians, and obviously would keep 1/2 of the cost savings. There was no separate hourly payment for, committee meetings or, getting together to talk about initiatives or monitor. There were no separate hourly payments, which is different from co-management. Usually, board and committee work, you do have hourly payments that's being paid from the base management fee. Cost savings, again, because of volume or value concerns, were always distributed on a per capita basis, not on a physician's individual performance. There was a requirement to rebase the cost savings every year so that you would not have double dipping on the savings from the first year. Only physicians who were performing the related procedures were permitted to participate. The OIG wanted all physicians performing those procedures to be invited, but obviously participation was voluntary. There was commonly quarterly reporting on changes in quality and costs. The term was usually anywhere from 1 to 3 years. Moving on. Other requirements included providing patients written notice of the gain sharing arrangement and wanting any initiatives that were undertaken to develop these cost savings to be based on evidence-based medical review and recommended the use of things like the U.S. FDA guidelines, among other things. To state the obvious, you shouldn't use this as a recruiting tool. You're not permitted. So it's like, hey, if you come over to our hospital, we'll have this gain sharing program, you'll get to get all this money. You can't do that. And those were pretty much the basic core requirements in the OIG advisory opinions. The most important thing, obviously, to always keep in mind here with respect to any of these arrangements is that failure to meet the requirements of a safe harbor or a special advisory bulletin or an OIG advisory opinion does not make the proposed arrangement illegal. The determination of legality will be a facts and circumstances test. Obviously, the closer the arrangement is to facts that were viewed favorably in a safe harbor or advisory bulletin or advisory opinion, is more likely to be found legal than one that has few approved features. But with that background and keeping in mind that you don't have to meet all of these to have an arrangement be legal, let's kind of now look at some of these OIG advisory opinion requirements, which are very stringent, and ask ourselves, are all of these required? So going to the next slide, as I say there in the introduction, OIG advisory opinions by their nature present very conservative fact patterns. Frankly, our view is always, well, if I was going to present an advisory opinion with such a conservative fact pattern, if I didn't already know it was legal, that didn't make me a very good healthcare lawyer. They are indeed very, very conservative fact patterns. So again, focusing on what do we think potentially we would not have to do but still be legal, let's review some of these requirements. The use of a program administrator to set and advance the cost savings initiatives. I would say this is something that can be done by the participating physicians and the hospital administrators after the gain sharing arrangement commences. It's in essence their duties. That's their duties to come up with these initiatives. And in particular, since you're only being paid if the cost savings actually show up, that seems to me to be a requirement that you could be a little bit more relaxed on. A cap on each initiative versus an overall cap. Again, as long as the overall cap is determined by an independent, nationally recognized valuation firm as being unrelated to the volume of value referrals and commercially reasonable, it seems to me that is something you should also be able to do. Offering the mandate to offer all physicians a right to participate versus just those physicians who are in a position to produce the meaningful cost savings. The point here, as I say in the parenthetical, over-inclusion of physicians may eliminate a meaningful incentive for physicians to produce the cost savings. And as we all know, there's usually in every service line one doctor or two doctors who just don't work and play well with others. And if that's the case and you're forced to include them, that may inhibit the development of the cost savings initiatives. So again, I think you could relax that particular requirement. Another requirement was to have, nevertheless, if you consolidated your purchasing and devices and supplies, implants, that you had to still maintain a full selection of them so the doctors could use them. And again, one of the other requirements is that you have to support that standardization by medical evidence. So if you've supported the standardization by medical evidence, such that there is no medical benefit to carrying a redundant device or supply, why should we have to do that? It just doesn't make sense, because obviously the whole point of consolidation of volumes into different devices and implants is to get better volume-based pricing from the supplier. So again, I think that's another one that you could probably just, as long as you're operating on medical-based evidence, you wouldn't have to carry the ones that you were otherwise eliminating. Critical component in this, as in the co-management, is you absolutely positively should get a fair market value opinion from an independent third-party expert to support the program. So with that, I'll turn it back over to John.
I know one of those independent fair market value experts, and he's going to speak real soon. I'll get to him as fast as I can. I want to talk through, so how should an organization go about setting up a Gainsharing and Comanagement program? As Tom mentioned, we recommend establishing a small group of physician leaders and hospital administrators to vet options and reach consensus on program design and the terms of the program. During the first phase of planning and modeling, we define the scope of the program, so which DRGs are included in the service line, where are our opportunities to reduce costs and improve quality, how should we best structure the service line to achieve the changes that we're targeting, right? And then in the funds flow design, we figure out how cost savings is measured, what baseline performance is, so baseline costs, and how actual performance will be measured to that baseline. And this is also the time period when the evaluations are performed for the program. And then the third phase is where we reach consensus on all terms of the arrangement, and legal counsel prepares the definitive agreements. The next several slides give some examples of the work that we go through. So slides 28 through 31 provide examples from a high-level analysis to more detailed of the cost savings opportunities and how you figure that out. So on this slide, it just shows, well, what would happen if we moved costs from everything that was above the 75th percentile back down to the 75th percentile. Slide 29 is where you start to look at, well, each doctor, what are their costs and where are their costs and how do they compare with one another? And this type of information is really good to start to share with the doctors so they can just start talking among themselves to start to understand, well, Dr. A, why am I so much more expensive on my OR supplies than you are? Slide 29 is where you can start to drill in on some of these costs on the per doctor basis. And then on slide 30, you can draw down, slide 31 is where you start to look, okay, well, what are our big cost savings opportunities? So specifically for supply chain, if we went to one vendor or we guaranteed a certain volume to this vendor, and that's where you start to engage the vendors in those conversations and figure out, well, what is our opportunity? And in this example, it shows you, well, the current spend is $3.3 million. The vendor in our contract, they're telling us they would only be charging us 1.9 for these exact same supplies if we could guarantee a certain level of volume to them. So their savings of $1.4 million right there. Slide 32, in addition to costs, so those are all part of the gain sharing perspective, but you'll also be looking at quality, areas of operational efficiency. This is an example of a really poorly performing OR where first case on time starts. You can see where everybody is over the baseline, and this is where you would start to identify where can we make meaningful impacts to our service line to improve the service line performance. in areas of efficiency, quality, patient satisfaction, other measures that are important to the service line. Okay. Slide 33. This lists out like best practice guiding principles in the development of these programs. And there's great flexibility in the design of a co-management and gain sharing program to meet stakeholder objectives. Simply mirroring the arrangements in the advisory opinions, as Tom was talking through, may not necessarily result in a program that achieves all of these guiding principles or others that may be important to your organization. In balancing fairness, slide 34, with consistency of the advisory opinions and other guidance, this is where you would start to hit some of the things that Tom just talked through. So we don't need to repeat some of these, but we think that for a hospital to be engaging doctors, you want the doctors who are actually making a meaningful impact in the service line, not just every doctor who might do a case every third week. So it's focusing on those doctors who are most impactful to the organization. Slide 35 gives an example of designing the sharing of savings in a more creative way than what you would find in any of the advisory opinions. And so the point here is, because in this example, you can see where we have 3 pools, but we also look at the service line in total and say, well, what's the savings across all 3 pools? And let's have doctors who may be assigned to one of these 3 pools be able to participate with each other, because there's decisions that are being made that affect all of the doctors, whether they're a spine doctor, or a joint replacement doctor, or a sports medicine doctor, and they all need to collaborate across those. Slide 36 summarizes the various areas involved in monitoring a gain sharing and co-management program. Monitoring involves verifying the cost savings and quality metrics are achieved, monitoring quality and outcome measures to protect against stinting. For patient care impact, monitoring patient volumes and payer mix for each of the physicians to protect against inappropriate reductions and limitations in patient care. For clinical effectiveness, it's verifying that the hospital is proactively monitoring and addressing any issues that may arise in the quality of care being delivered to patients due to supply changes or standardization. And then finally, for referral patterns, analyzing those patterns and monitoring for changes in volume or payer mix due to any financial rewards the doctors might be achieving. And so often in these programs, ECGs served as a monitor for these programs to make sure that we're compliant with those guidelines that have been set out. Now, the next several slides, 37, 38, and 39, walk through funds flow for a program. This slide just shows we've got co-management on the left and gain sharing on the right. And with each of them, you're figuring out how the funds would be provided, and those go into a funding pool that then gets distributed to the doctors. 38 focuses on the co-management funding portion. And here you can see that there's a base compensation of $100,000, and then there's an opportunity to earn an additional $210,000 in incentive compensation, with each of these 7 metrics having a max payout of $30,000. So you can see where we kind of picked where they were versus baseline, what the real performance was, to figure out what the total compensation would be, and then how much that would go out to each of the participating physicians. Slide 39 looks at a gain sharing view. Here, each DRG is measured, and we can compare actual performance to baseline. I want to move on to 40, because what this does is Tom referred to how gain sharing used to be put into a lot of co-management arrangements, and now we sort of separate it out. This is how it would fit within a co-management arrangement, and it could be valued separately. But you could see where you would have this was the exact same slide except for the last row of it. We added the gain sharing piece. If you move to slide 41, this lays out how we can easily, it's pretty easy math to figure out what amount of savings over baseline you need to make to be able to achieve a certain level of payout, and have this mirror what a gain sharing program would actually generate. Okay. So I want to turn it over to Jason to talk through some F&B considerations.
Thanks, John. So the key piece that a lot of folks ask about regarding these types of arrangements is why are these different than your traditional fair market valuations, and there's a couple of reasons why these are different. One is that there aren't large nationally established benchmarks that folks can refer against typically for these types of arrangements, and secondly, the outcomes are unknown. They're on a spectrum of outcomes, unlike a typical physician productivity or physician compensation type arrangement. And so because of those factors, we really have to look at three key elements that go into the analysis of either a co-management arrangement or a gain sharing arrangement. Those include, of course, all of the elements that Tom and John have been talking about: the volume expected, the cost tabulation, the effective income statement of the division or service line that you're managing. We establish a distribution maximum in terms of an expected compensation paid back to the physician under the terms that are laid out by the arrangement. And then we actually run Monte Carlo and program savings projections to estimate what that likely outcome would be at various levels of performance. And so when you take all three of those elements together, that forms the resulting analysis for the FMV. Structurally, as we think about the different elements here on 43, there are pieces of the arrangement that can impact how that outcome result looks, whether that's the allowance for administrative fees, whether that's the symmetric or asymmetric risk structure that is set up in either the co-management or the gain sharing arrangement, et cetera. There's a number of elements that we think about and want to incorporate in our modeling, in our projections, to ensure that the expected dollars are in line with both the maximums that we've calculated for the particular arrangement, as well as what the likely result of the efforts of the physicians are going to be, whether that's on a co-management side or a gain sharing side. Lastly, on slide 44, these charts illustrate some of the types of analyses that we'll commonly do for these arrangements. The job of evaluator in many cases is to ensure that the arrangement itself is fair market value, as well as all of the expected outcomes of that arrangement. And so when you're looking at the likely volume of activity, when you're looking at the likely savings projections or savings amounts for different volumes tiers in your gain sharing arrangements, we have to evaluate all of those pieces to ensure that the arrangement will meet both fair market value and commercial reasonableness. And one of the key things that you want to analyze for is ensuring that the participants, the physicians, aren't simply earning a windfall through no significant effort or through no significant change in behavior. And that's what partly this analysis is designed to do. So a lot of key elements that go into both the assessment of the structure, the projections of the dollars, and the volume comprise the robust fair market value analysis that you should expect when you're entering into these types of arrangements.
Jason, we've received several questions and that I think revolve around your area of expertise, and around how do you account for, to your point that we need to account for physicians' participation in it and their how they helped produce some of the savings. What happens in events, or is it okay if something happens during the program year? The health system negotiates new contracts for supplies, and that generates some of the savings. Do health systems need to be concerned about that, or how does the program need to take that into consideration in terms of factoring in the savings that the physicians get credit for, or the program gets credit for. Does that make sense?
Yeah, absolutely. And in fact, I believe that one of the intended outcomes of these types of arrangements is that the hospital is entering into some negotiations, and through the coordination and efforts of the physician groups, whether that's the co-management team or the gain-sharing negotiation team, are able to reach an agreement that allows the hospital to reach a higher level of volume tier and subsequently the improved rates. Now, what you're talking about potentially could be the formation of let's say, a gain-sharing committee or gain-sharing arrangement that is functioning in parallel with some vendor negotiations that are going on, and potentially a windfall for the group is that the hospital or health system is able to achieve a discount outside of any coordination or agreement that the physicians have entered into. And so we obviously have to keep an eye on the potential negotiations that are going on while that group is coordinating. But outside of malicious intent by those physicians, we would typically incorporate that expected discount that was outside of the efforts of the group into the calculation, and so that is usually folded into the baseline going into the effective program year, if you will, of the gain sharing arrangement.
And then maybe one last question before we need to wrap things up. There were two questions just around the baseline performance. So maybe Tom and Jason, you can tackle this one, and Jason, you can go first, then hand it over to Tom. And that was just how long is there any guidance or hard and fast rules around how long the baseline performance or baseline calculation can be used in terms of calculating savings?
So under co-management, my understanding is that those can be used for the duration of the arrangement, but for gain sharings, the guidance is to rebase on an annual basis for the duration of the agreement. If it's a 2-year agreement or a 3-year agreement, you're rebasing every year to ensure that you don't get a double counting of that additional savings. Tom, I don't know if you have a different perspective.
Yeah, that is correct on both scores.
Great. Well, I wanted to thank you to our presenters. And this is a wealth of information. And thanks for everyone who dialed in and participated, and for all of your questions. There were a few questions that we weren't able to get to, but we will make sure to reach out with specifically to address those. Before we do depart, I would like to remind you that you'll see on the slide a reminder to complete the electronic survey before you exit, and we certainly appreciate any feedback you have for the presenters and today's program. And with that, thank you again to everyone for joining, and have a great rest of the day.